السلام عليكم.
وعليكم السلام ورحمة الله.
الله يعطيك العافية، شو أخبارك؟
الحمد لله، شلونك انت؟
والله الحمد لله بخير، كله تمام.
كله
عطو.
تمام، ألف نعمة. ألف
الحمد
نعمة،
لله.
cannot complain.
الحمد لله. ما شاء الله عليك، السي في بدي ربع ساعة لحتى أقرأ لهم إياها البايو.
لك حبيبي، أنا أولد، هيك بيصير لما الواحد بيكون صار له زمان بالمصلحة. شو بده يساوي؟ الحمد لله.
الحمد لله.
يعني it keep adding up، بس it's years of work. تعرف أنت،
الحمد
لما
لله.
كنا شباب، أيام كنا شباب كان عندنا a lot of
لا
enthusiasm.
هلا شباب شو بتحكي؟
هلا I'm trying والله to slow down a little bit.
الله يعطيك العافية.
الله يعافيك يا رب.
هلا هن عادة يعني هو 8، بس تعرف نحن دائما بتأخروا لجوين. So usually like 8:04 8:03
مو
يعني شوف
مشكلة.
العدد يعني.
احنا بنبلش على 8:05 اذا بتحب،
يا
وريجاردلس يعني
يا
regardless of
وهي
who's there.
وهي لازم تكون مسجلة. أنا قلت لها لسلام.
Yeah,
Oh recording yeah so
it is
it's good.
recording.
Yeah.
إذا عندك حدا، واحد سألني اليوم
ايه.
إذا if somebody's interested in taking over or partner in a primary care practice be Bloomfield. So if you guys know somebody for primary care who may be interested, Ella, who's looking for like a part-time job or to pick up a new practice or
Okay.
partner with a practice, actually. They're looking for somebody to come in
Okay.
Square Lake and Updike.
Okay. Nice area.
Mhm.
Yeah.
أنا هجيب لي كاسة مية بين ما يجي الشعب.
Yeah.
Yep.
Hello, everyone. Good evening. I know it's 8 o'clock. We'll wait a couple minutes to have more people joining, so we'll start the webinar in a couple minutes, inshallah.
Recording in progress.
Good evening, everyone. Thank you for joining us with Sam's monthly webinar. I will start just a couple announcements. We'd like to have you in our SAM Symposium in Orlando. It's going to be February 14 through February 16. So if you haven't registered yet, please do so. It's going to be a great symposium, especially after liberation of Syria. Also, please save the date for our first international SAMS conference in Damascus, Syria. Going to be July 4th through July 6th. Hopefully soon we'll get you more information about registration and hotel, etc. Tonight, with pleasure, I like to welcome Dr. Ammar Hatahet, clinical professor of medicine at Michigan State University. MashaAllah, Dr. Hatahet's CV would take me like 20 minutes to go over all the achievement, accomplishments that he been done in the last 30 years. He's dual board certified in internal medicine and obesity medicine. Dr. Hatahet currently in private practice in Bloomfield Hills, Michigan. He teaches resident and student from Michigan State University. He runs the Hatahet Center for Weight Management, multidisciplinary obesity clinic since 2016. In addition to that, Dr. Hatahet is the chairperson for corporate-wide McLaren Healthcare, IRB, since February 2012, and he's the program director for the residency program of internal medicine at the same institution since June 18. Tonight, he's going to talk with us about weight loss and fasting, and it's a very important topic, and we'll need it, especially after the holiday and prior to Ramadan. Please welcome with me, Dr. Hatahet.
Thank you, Nidal, and everybody. I hope this will be quite enlightening as far as weight regulation. I get these questions all the time. I'll make it a little bit informal. I will have a couple of cases as well, so we'll have plenty of time for questions after when we're done. But kind of an overview of what I'm going to try to cover today. To understand the neurohormonal regulation of weight and obesity. And the reason actually I was asked, I think, to do this at this point in time, correct me if I'm wrong, Nidal, it was because Ramadan is coming up. And a lot of people would like to take that opportunity to lose weight during Ramadan. However, believe it or not, most people actually do not lose weight in Ramadan. Some people actually do gain quite a bit of weight. So we'll talk a little bit about how the body regulates that. And we'll talk specifically about in the context of fasting. And you hear a lot about intermittent fasting. It's been now a fad for the last couple of years. Everybody wants to do intermittent fasting, something that we do every single night when we go to sleep, as you know. We'll talk about medications in particular that we sometimes prescribe that make the obesity worse, at least for some of these categories of these meds that we'll discuss. And we'll talk a little bit about what's currently approved by the FDA for weight loss and what's coming actually down the pike. The upcoming couple of years, there'll be a few products that will be new on the market. Some have totally new mechanism of action. Some are actually old but modified and improved, if you will. So I'm just going to put in a couple of cases first and put things in perspective. 39-year-old man is evaluated during a new patient visit. This question actually came from a board review for internal medicine. Concerned about gradual weight gain over the last several years. He does not pay much attention to his diet and describes his lifestyle as generally sedentary. He does not use tobacco products and does not drink. He reports no problems with non-restorative sleep or daytime hypersomnolence. And he takes no medication. So specifically, they're letting us know he does not have probably a whole lot of sleep apnea, does not have other comorbidities. As you can see in his vital signs, his blood pressure is mildly elevated, body mass index of 35, which puts him in obesity class 2. Waist circumference is 107, and the remainder of the exam is normal. And this is actually the question that they posted in internal medicine residents. What would be the most appropriate test to perform next? A stress test, or you look at the hepatic ultrasonography looking for NASH, now it's called MASH. Overnight pulse thermography for sleep apnea. Do you check his lipid profile or do you check thyroid? We'll come to that towards the end. It just kind of setting the stage for what you're going to be encountering when we talk about obesity in general. Another case that's kind of a little bit more complicated for this one. This is a 48-year-old woman who's actually diabetic with a body mass index of 39 and an A1C of 8.2. This patient is already taken, as you can see here, she's on liraglutide, GLP-1 receptor agonist, plus an ACE inhibitor and metformin. So medically speaking, she's on some therapy, and she did gain some weight as well in the last few months. These two cases kind of describe, the bulk of what you're going to see. Obesity is rampant everywhere, and you're going to have to come across them and figure out how to treat them. So this is the question for that lady, or the second patient. What would you do for her at this point in time? Offer her bariatric surgery, put her on semaglutide, knowing that she's already been on liraglutide. Do you refer to a dietitian, or do you put her on a very low caloric intake diet? Okay. So first and foremost, let's talk first about the definition. This definition has really not changed as far as what obesity is. We still look at the body mass index as an indicator. Body mass index is basically weight times 703 divided into your height if you're using the pounds and inches. And if you're using just kilograms and centimeters, then you talk about weight in kilograms divided by your height squared in centimeters, in meters. We could use also waist circumference to measure adiposity, but there are other ways as well to look at the fat content. And really what we're going after is not necessarily the exact scale number as much as the composition of the body. So we infer from high, large, or very large body mass index that you may have excess fat. However, that is not necessarily true all the time. And I will talk about the limitation of just using the body mass index. It's very easy attainable. It's not that difficult in your practice to get your weight, your height, and you're done. You come up with the number. Or to measure waist circumference with a measuring tape, and anything above 100 is problematic. You could look at the fat content as well through waist to hip ratio. You could look for skin folds. We use a caliper in the office. You could do the plethysmography as well. We sometimes, in the office, we use the bioelectric impedance. You put them on the scale and that measure electricity going across. And that also kind of infers from that the body composition. You could become much more kind of complicated when you want to order like ultrasound or DEXA scan. A single slice tomography across the abdomen could also be very helpful. So it would be a MRI. Those things are not necessarily practical. We sometimes in our actually office, we use the DEXA scan primarily for the elderly to find exactly their body composition. But for all practical purposes, you don't need all this stuff. Limitation of the body mass index. Why is it not necessarily the best thing? Like I said, it's very easy attainable. However, you could imagine somebody who's very muscular. You're not going to get a good number. You're going to have a large muscle mass, but that is not necessarily a lot of fat. So bodybuilder is going to be elevated, artificially or falsely. And in the elderly, particularly in the Asian population, you're going to have actually a normal body mass index. However, there's 40% of that is in fat. In Japan, actually twice in my career, actually I taught in Japan, in Okinawa, they actually use a lower BMI index, 26.5 as a cutoff for obesity, not the one that we're used to here in the US at 30. This is the waist measurement. And if you're going to do the waist measure, make sure that actually your staff is consistent in how you measure it. Right around the umbilicus, you run the measuring tape, take a deep breath, let it all out, snugly measure, use the measuring tape. But you have to have consistency as well. So you have to train your folks how to do this. You could use the graph as well. Those are quite available everywhere. And the reason I like this because it gives you a visual with the colors. So the green is a good body mass index. That is your normal numbers. The yellow is overweight and the red is obesity. So the problem with obesity in general is not necessarily aesthetically you don't look fine as much as you have comorbid conditions. Most patients with obesity do have a comorbid condition. And if you have not detected it yet, then you have not looked deep enough. We don't believe there's actually such a thing as a healthy obese patient. You just have not looked enough. Mechanically, it's almost impossible to actually have a healthy person with a BMI of 30, 31, if you're looking at the fat content. So what happens with obesity? Depression, pseudomonas cerebri, migraine, obstructive sleep apnea, asthma, restrictive lung disease, COPD, fatty liver, type 2 diabetes, of course, metabolic syndrome, all that stuff. Cardiovascular disease, hypertension, gout. So you have the metabolic derangement and you have the mechanical derangement. So incontinence, often we don't think of it as a complication. Reflux, we don't think of it as a complication of obesity. They're all actually part of the obesity complex. It's estimated that probably about 13 to 14% of cancers actually, 30 to 40% of cancers are related directly to obesity. About 13 cancers in general that we assume they have a strong relationship with obesity, particularly gynecological cancers. And as you would expect, as the BMI goes up, the prevalence of all these diseases also go up at different degrees. So when we break them down to obesity 1, 2, and 3, it's not like, you jump all of a sudden from low risk to moderate risk or moderate risk to high risk. This is a continuum. The only really utility for the exact numbers is if you're going to need to authorize a medication because insurance companies would like to use a particular cutoff. But otherwise, it's a continuum. It's not like your risk was normal at 29.9 and now all of a sudden it's gone up when you go to 30. We covered this. Okay. So we'll talk a little bit about what happens with obesity, at least our current understanding of the etiology of obesity. The simple explanation, when I went to medical school some 700 years ago, we were taught energy in, energy out. Is that balance? And if you get a lot of calories in and you don't expend them, basically you're going to gain weight. Well, as it turns out, that is really too simplistic. There are many other factors that are playing a major role in causing obesity, whether it's the environment, the biology, and the genetics. I'm going to spend some time actually in the biology because the environment is self-explanatory to a great deal. Within the genetics, we know, at least from the twin studies, that about 40 to 70% of the variation in obesity-related phenotypes, 40 to 70% is actually inherited. That is a bit problematic once again, because you could see a patient who comes in with a BMI of, let's say, 35. I see kids in my practice as well. So these kids were brought in by their parents, 17-year-old child with type 2 diabetes, BMI of 35, 36. And you look at the parents, they have a BMI of 40. Right? So these kind of put things in perspective. But these variations in the phenotypes, it's not only the BMI, fat mass, and what have you, even leptin levels, we think is partially inherited as well. We know at least of 100 genes that have been implicated in obesity. So it's not like a single gene that you could switch on and off. For leptin deficient patients, that is a unique case, only very few families in the world that actually have leptin deficiency. That is inherited clearly with a single gene, but those are very rare. Other things that would also play a role within the hereditary side, energy expenditure, whether it's using beta oxidization or other ways for storage. And the reason this is important because somebody's going to come to you and say, well, you know, my friend, my cousin, whoever it may be, they eat everything they want and they would never gain a pound. That is true. They have a different metabolism. They have different genes. Eventually, it may catch up to them, but for the most part, most of us are not blessed with that kind of gene that allows us to burn off these calories. I'm not going to spend a whole lot of time on how we burn off calories. But within the environment, similarly, so this was from economist back, maybe this is a 15-year-old, maybe more than 20-year-old actually slide. And basically, this is, you know, how we developed, I guess, over time. And the very last move that, you know, going from, if you look to the right side of the slide, now this guy is carrying a Coke in his hand. Too bad he doesn't have a hamburger as well. There's not a single theory actually that could explain this final transition, which happened the last 40, 50 years. There's plenty of theories, including a viral etiology with the adenovirus AD36, environment, and biology that has probably changed. So biology, which is what I want to focus on today for today's topic, at least, so we could relate back to the issue of fasting. Weight is very tightly regulated, just like every other function in our body. We have anorexigens, and we have orexigens. Within this is the body physiology. So we start talking about how the body regulates and why it needs to regulate. And I'm going to want you to kind of think of the baby who comes out of the womb. All of a sudden, you have a newborn, and that newborn does not have the drive to eat. In essence, has no hunger. What happens to that child? It will die, basically, right? So the body has to have the ability to initiate that hunger. That is your neuropeptide Y, what you're seeing on the right side. And it has to also accommodate our other needs for why we eat, such as satiety, such as, you know, wellness, such as I feel good now. So the way that actually it works, you have on the right side the neuropeptide Y, comes up from the stomach, goes over to the brain, and the ghrelin comes up from the stomach, goes to the neuropeptide Y, first order motor neuron in the brain, activates the agorated peptide, and both will trigger the hypothalamus the need to eat. So that is a signal to say, I need now to, I'm hungry, right? In the latter part of the hypothalamus, you also get the MCH. That has a different mechanism for inducing for why I want to eat. So now I have two mechanisms by which I feel like I need to eat. On the left side is what you're saying, all these things that tells us you do not need to eat, right? So the POMC, some of those actually are now a target for therapeutic interventions. So we'll talk about some of those as well. But the left side of the slide is basically telling us you have enough, you don't need to eat. CART in particular, if you have put anybody on, let's say Adderall and Ritalin, and you see that they don't really eat, that's why they don't eat. It stimulates actually the CART receptor in the brain. The point really to this, and I have a couple of other slides as well, just to show that this is really very tightly regulated intervention as far as where the body weight needs to be. We were born, we're supposed to be staying lean since we're gatherers and hunters. Something happens over time that messes up with biology that we're just describing. This is more illustrative of what I was talking about. And we'll talk about some of these triggers that you see on the bottom for how the brain actually senses it. So if you think about the signals that we get, the leptin comes from the fat, tells the brain that we have enough energy. Ghrelin comes from the stomach, goes to the brain, tells the brain, I need to eat, you're hungry. This is where the neuropeptide Y comes in. What happens is other compensatory factors come in through the GI tract as well, the incretin. So as the food bolus travels into the GI tract, you're getting these signals back to the brain that tells the brain, stop eating. Oxyntomodulin is now actually in phase 3 trial. We're going to talk about towards the end of the presentation. GLP-1 we already have as a therapeutic agent, semaglutide, tirzepatide as well. Amylin, which is also an appetite suppressor. People always think amylin and insulin are, I'm sorry, they think of insulin as an obesogenic drug. Actually, insulin suppresses appetite once it crosses the blood-brain barrier for the same reason. You have too much sugar now, you need to stop eating. So amylin is now also in phase 3 trials for weight loss. And you have a bunch of other factors as well that come from the fatty tissue, the adiponectin, TNF, and what have you. They all contribute to the neurohormonal regulation of our body mass index, our basically muscle mass. So when we get hungry, again, it's ghrelin that stimulates the neuropeptide Y and says we have to eat. And as that food bolus travels, you get all these other things that tells the brain stop eating. I find it quite interesting that one thing could actually make us eat so much from a hunger perspective. I haven't talked about when you're stressed out or when you're bored or when you have, the food is out there because it tastes good, as you can imagine. This has nothing to do actually with the ghrelin. But we have all these other factors that play in telling the brain stop eating. So we're going to circle back to that when we talk about what happens when you lose the weight. But when you get your first, the patient you want to address obesity with, and you're going to talk to them about what makes them eat and what have you, you have to understand a lot of other things as well. The history of when this started. One of the questions that we ask, how much did you weigh out of high school? How much did you weigh actually after having the second child? How much did you weigh before COVID? There are certain times in your life when all of a sudden these mechanisms have been impaired. Sometimes we see it actually with steroids. They were hospitalized, divorced. Something happened that changes the normal physiology that was keeping weight in check. Within the exam, in addition to having to pay additional physical exam, remember that, and this has actually been shown also in trials and studies, the obese patient does not get a detailed exam like a lean person. One, there's this kind of bias towards obese patients in general. Two, that you have limitation as far as the exam tables and then the chairs that you use. Equipment, you have to have a large cuff. You can't use a regular cuff when you measure the blood pressure. But even your exam skills, if you're going to put a stethoscope, you're not going to hear as much. And certainly if you're going to examine the belly, you're not going to feel as much when you have an obese patient. So there's a lot of limitations that you have to account for. The laboratory tests that we, generally speaking, order in the office are what you see on the screen, but you may very well add more stuff. And it really kind of depends on the patient that you have at hand. Some patients we check for testosterone. This includes women as well. Sometimes we check for prolactin, with the thought of something is stimulating that additional weight gain that was not there before. It is critical, absolutely critical, before you start treating anybody with obesity, is to look for secondary causes. A bunch of disease can certainly cause it. Medication, if you've ever gone on steroids, you know their effect on appetite. Birth control pills diminishes the ability to burn calories by design if you have estrogen on board. Many of the psychotropic agents, antipsychotics, Zyprexa in particular. So those are the things that you have to look for as part of addressing the obesity problem, the obesity that you have to work with the patient. Tricyclics, monoamine oxidase inhibitors. Most of your SSRIs have been implicated with weight gain, with the exception of Prozac. And again, like I said, your other drugs, the psychoactive drugs. The only one that you see lowering the weight is bupropion, which is part of Contrave, which is indicated for long-term management of weight loss in conjunction with naltrexone. However, you can't use it with seizures. We'll cover those. So these guidelines for treating obesity have really changed very little in the last 30, 40 years. And I did not mention earlier about these BMI charts, where initially when they came out in the late 70s, they were primarily being put together actually by the insurance industry. They were trying to stratify patients' risk. So when they charge them for their premium, they would need to know how much to charge. So the actuaries who work for the insurance industry who came with these BMI classifications many, many years ago. What you're seeing on the screen has little changed since over the last maybe 20, 30 years. The CDC have said the same thing and NIH have said the same thing. Overweight, 25 up to 26.5, 26.9, you want to advise for diet and activity. If you're at 27 to 29.9, so you're overweight but not obese, and you have a comorbid condition, you do want to intervene with medication as well on top of diet and exercise. You do not want to wait until the body mass index hit 30, 35 if you have a comorbid condition. And there's a reason for it. If you remember this slide where I showed that incrementally other comorbid conditions actually get worse with BMI going up. Diabetes in particular, when you hit 27 is when that incidence goes up. And then you do want to consider surgery. Actually, now it's been advocated to even lower the surgery down to BMI of 30 with comorbid conditions and 35 in the absence of comorbid conditions. What you're seeing on this slide is actually what the insurance pays for right now. But you could certainly consider bariatric surgery for somebody with a BMI of 32, 33 if they have a comorbid condition. And we'll talk about why that actually has changed as well. So that is on the management side. So to go back about how we regulate this way, I went over these hormones and their endocrine, the incretin effects and why the body likes to control it so tightly. We believe there is a set point that you are born with as far as what your body weight should be. Your mass index should be, your adiposity should be. That is, again, 50% is inherited through your genes. The body likes that set point. So throughout your high school years and your college years, you eat a whole lot more than your body could actually dispose of. The weight does not change. It continues to literally protect that set point for a while. It comes to the point that it could no longer do that. How does it do it? So going back to this, basic definitions from medical school days, and I'm pretty sure there are a few medical students with us today. 2/3 of our daily energy expenditure is what we call resting energy expenditure, the RE. That is basically the energy I use doing nothing, absolutely nothing. This is the kidneys working, the liver working, the brain, all that stuff. So I burn most of my calories doing nothing. Just being alive in itself is good enough for me to burn most of my calories. When we harp on exercise, and we don't actually do that anymore like we used to, because it has a very marginal effect on the amount of energy that we actually burn. And that's what you're looking at the bottom. So the thermic effect of food often is also underestimated. We say it's 5 to 10% of the energy that we take is spent actually in the thermic effect of food. That's the amount of energy you need to digest the food, absorb it, store it. However, that is not all the same, because for carbs, for example, we actually use about 10%. For fat, we use only 2%. For protein, we use up to 20% of the energy. So we are taught in medical school for a gram of protein, you get 4 kilocalories. For a gram of carbs, you get 4 kilocalories. That's actually to generate in the lab. That's an experiment in vitro, not in vivo. The body does not use it that way when it uses in vivo. It uses up to 20% just to break down the protein to get it into the system. 1/3 is spent again in the exercise side, and we break the exercise into two types. One that's daily activity, just going around, maybe doing some shopping, maybe doing my cleaning. And another half of that, so we talk about now only 15% is what's considered to be exercise related. And that's why exercise is really not a very good way of losing the weight if you're not lose the weight. Ramadan is coming up, and often patients, sometimes they decide we're going to do a ketoacidosis, or a ketogenic diet. We're going to do a keto diet. We're going to do Atkins. We do Ramadan. Now it's going to be in March, so it's not going to be as bad as it used to be in the summer, 16, 17 hours. But what happens when actually the body stops eating? First, we're going to be using the glycogen that's in the liver. So you could imagine not eating for 16, 17 hours. You don't pass out. You still have kind of energy coming from the glycogen. If I eat a lot of food between Maghrib and Fajr, right, from after iftar until suhoor, I restored everything and maybe even in excess. I'm not going to lose weight. I have enough. So one of the key things for when people go into this, like I said, when they decide I'm not going to eat at all, I'm going to do a food abstinence, I'm going to do intermittent fasting, you have to account for the fact that actually the body is able to handle this with no problems. 24 hours, I'm good. Now, after that, once you start going into real ketosis, which creates really a problem for the ketogenic diet and for Atkins, when you go into ketosis, now you're going to go through a mandatory negative nitrogen balance. You're going to lose protein. That is by design. This decreases your lean body mass. What burns off the calories? Lean body mass. So when you have a less lean body mass, now you're going to be able to less burn calories. And certainly on day 7 of, if you do semi-starvation, this is your Atkins type with the ketogenic, now it becomes the obligatory or the predominant fuel, and you lose a lot of muscles. We work with people actually who come in on Atkins, they're about to start Atkins, or they left Atkins and now they gain more than they actually lost. And you'll hear this story often when people go on Atkins diet, ketogenic diet, they gain more than they actually lost once they come off of it. The body is now much more efficient in storage. All right. So here's the problem. I went over the hormonal regulation at length for a reason. When you decide to lose the weight, we all have done as adults at one point in time, I'm going to control the weight, we're going to lose it, we're going to do something. How does the body react? The body, like I said, has a set point. How is it going to react? Well, as it turns out, the body decides, I don't like the new weight. I know you're trying to lose weight. I'm at now 250 pounds, 120 kilos. I don't like that. So what does it do? It increases ghrelin. Ghrelin job is to increase hunger. So now that you lost good 20, 30 pounds, 10, 15 kilos, all of a sudden the body's actually reacting in a reverse way. It increases the ghrelin, increases your hunger. Satiety hormones that I described, all of them, they go down. To make things worse, your resting expenditure, remember we talked about that resting expenditure? This is where you spend 2/3 of your calories. That goes down as well. So here you are trying to do the right thing, and your body's going to actually push you into the opposite direction. That's why it almost never works. Almost never it works where people can actually, adults past the age of 30, 35, 40, it's almost impossible to lose the weight and keep it off without an intervention, whether it's surgery or medication, because your body functions are working really against you. I'm going to skip over the popular diets. I'm going to leave it probably till we get to the questions. So let's put those have been tried and has been proven to be not effective. Stimulants of different sorts, caffeine, theophylline, thyroxine, is going to make you lose more muscle than it's going to make you lose more fat. Mawang ephedra, that's the Chinese herb, has been actually taken off the market because increased risk of strokes. The HCA does not work. Those have all been done. Beta-HCG injectable has been tested in randomized controlled trials, does not make you lose more weight, but increases your risk for hepatitis. So then what are you left with for management? You're going to either work on the expenditure, and we don't really have, and this is the right side of that balance of the scale. You could work on the expenditure. We don't have a very effective way right now of increasing your metabolism enough to make you lose fat without losing muscles, major muscle mass, which, by the way, all weight loss programs, every single one of them, will make you lose weight with both muscle and fat. Our job is really to have you lose more fat than muscle. And that's when we talk about specific exercise types that you want to continue with, like resistance exercises. On the left-hand side of the screen is what you're seeing about energy intake. We want to reduce our caloric intake, no question, right? So phentermine works on neuropeptide Y. As you recall from the early slides, Ghrelin comes out of the stomach, travels up through the first order neuron, neuropeptide. Ghrelin leaves the stomach up through the first motor order neuron to neuropeptide Y that stimulates your appetite. That's where phentermine works. Tiotropium and phentermine is in the same category. The other meds that are indicated by the FDA in the United States include Qsymia, that is small dose of phentermine plus the pyramate, Topamax. Contrave, that is the bupropion, Wellbutrin, with naltrexone. Saxenda, that's liraglutide, it's once a day GLP-1 receptor agonist. Orlistat, that works on the intestinal absorption, it's basically a lipase inhibitor. So, and of course, surgical option. What you're seeing in italic here, the semaglutide and tirzepatide, those are the currently that's taken up the market, and this is why it's costing now healthcare supposedly so much money to cover them. Those are your Ozempic, and not Ozempic. Those are your Wegovy and your Zepbound. So Ozempic for diabetes, comparable to it is your Wegovy for weight loss, and Mounjaro for diabetes, and comparable to it is the Zepbound, that is tirzepatide. These are the dosing that are currently available. These meds, as you could imagine, when we went back and talked about a few slides back, we talked about GLP-1. So the GLP-1 naturally occurs in the distal part of the small intestine. Why? This we used to call the iliac brake. So as the food bolus travels all the way, you have the cholecystokinin, then you have the GIP. All of these factors go into the brain to tell the brain to stop eating. The last one in that cascade is the GLP-1 that comes out of the terminal ileum. We are able to manufacture that GLP-1 into an analog under semaglutide, and tirzepatide is actually a dual receptor agonist. It's a GIP and a GLP-1. So as you could imagine, when you give them as an injection, they go to the brain to tell the brain what the normal physiology would have told the brain, which is stop eating. So choosing the right medicine, let's make sure that we're on time, because I do want to leave some time for questions when we're done. Choosing the right medicine for treating obesity is going to really depend on a lot of factors. Comorbid conditions, history of stroke, GI pathology, depression, addiction, and so forth. Bupropion is contraindicated in somebody who has seizures. It lowers seizure threshold, so you can't use it. Topiramate is teratogenic, left palate, so you can't use it in somebody who's not using birth control. Somebody who has GI pathology already, to give them a GLP-1 receptor agonist with a lot of GI side effects may not be a good idea. So as you go through the history and you figure out, well, I need to do something, I just need to figure out what is that I need to prescribe. And the intent of the medicines really, and I tell this to patients, none of these medicines make you lose weight, by the way. They help you in making a decision to eat less. That's what they do. They do not increase your metabolism enough to burn off the calories. So choosing the right medicine is really a long discussion with the patient. Our first encounter with patients usually is about 1 hour for the initial assessment. We go through all these factors. We have them fill out the survey, and I'll make sure that survey is available to you if you'd like to see it. This is the intake that we actually use. And it does ask them specifically about eating disorders because you have to account for it as well. Then we talk about what's really reasonably affordable. Are you going to pay $500 a month? Can you pay $500 a month for weight loss endeavor, which could very well be for the next 5, 10, 15 years or whatever it may be, or you can't? These are the options that we usually discuss with the patient. Okay. It's really important to keep in mind the newer drugs right now, even the ones that are coming down the pike, on average, weight loss is about 20%. For some patients, 20% may not be enough. If I started with 200 and I want to go down to 120, then maybe that's not going to cut it. We have patients in the office who lost 130, 140 pounds, multiple patients, not one, not two, multiple patients, over 100 pounds that they lost, but that is really not the norm. On average, the newer drugs, weight loss is anywhere from 15 to 20%. However, keep in mind that even 5% weight loss is actually medically relevant. It's simple. It lowers your blood pressure and it lowers your triglycerides. It improves your lipid profile, even 5%. 5%, that would be what? 10 pounds out of 200 pounds person, right? So the 5 kilograms out of 100 kilograms is really very important, medically speaking. The other point that is really important to make, that they should only be prescribed to patients who are willing to change their lifestyle, change their relationship with food, have to be committed. This is not a quick fix. As you noticed when I was talking initially about how the body adjusts, obesity is a chronic disease. It gets worse over time. So it's a progressive disease. Furthermore, it's relapsing. Remember, we talk about going through these different diets and ups and downs, and it's a relapsing chronic disease that has to be treated accordingly. So don't expect a quick fix. Not going to happen. And that's why when patients come in and say, just give me the pill or give me the injection, we say, we can't do that. It has to be a long-term commitment. This is the last slide that I have actually that I want to discuss before we go into the questions. What is coming down the pike? In production right now, all these products are actually right now in phase 3 trials. Very exciting. The best that you can get from any of those is about 20% or so, comparable to what we have tirzepatide at 50 milligram dose, about 21 or so. So the first one, which is really kind of going to be a big deal, I suspect personally. The orforglipron and the danuglipron, made by 2 different companies, Eli Lilly, and the other one is made by Pfizer. Those are actually oral pills. The semaglutide is a polypeptide, has to be given as an injection with the exception for Rybelsus that we use for diabetes. A different composition with the snack molecule. It's a discussion for a different day. But in general, it's very hard to get a polypeptide into your system through a pill. Those are actually stimulate GLP-1 receptor without having to be a polypeptide. So those are a small molecule and they can go directly to GLP-1 receptor and stimulate it. They're not as potent as the injections, at least in phase 3 trials so far, but something that we'll be expecting to see as a pill. Again, this would be comparable to what we currently have for diabetes with the semaglutide Rybelsus. Another product that's also coming out in phase 3 trials right now, we may see it in 2026 possibly. Mazdutide is an oxygen demodulin analog. Remember we talked about that oxygen demodulin that was on the left-hand side of the slide? That is an endogenous hormone that the body makes. We're going to make an analog that stimulates both GLP-1 and glucagon receptor. Third product is going to come as well in phase 3 trial right now is the retatrutide. This is actually triple receptor. So we've gone from GLP-1, GIP-1, which is what we currently know as tirzepatide, known in the US as Mounjaro and Zepbound. Now we're adding a third leg to it, glucagon receptor agonist. Also in phase 3 trial. Currently, Eli Lilly actually is working on it. And the last one that's right, this is now in phase 3 trial. We're probably going to even see more and more in the next 4 or 5 years as we uncover more about the biology of weight regulation. CagriSema is an interesting molecule as well. It combines amylin and GLP-1 receptor agonist. Those are 2 separate molecules. So amylin comes from the pancreas co-secreted with insulin from the same vacuole. And we use it for type 1 and type 2 diabetes. It just has to be given with each meal. So it's a short acting. What they're working with the CagriSema is actually once a week formulation for both the GLP-1 part as well as the amylin part. Also phase 3 trial. In the last month, I want to say, in December, they just actually published their initial data, 20% weight loss. Back in the days, before we had any of these molecules, we were talking about 8%, 9% weight loss. We were very excited when Qsymia came out. It was 9% or so. Now we don't really accept anything that's under 15%. We say, yeah, it's okay, because we expect now more. And when we talk about 20%, talk about most of your patients will lose 20%. Some patients, like I said, we've seen in the office where they use 30% of their body weight, 40% of their body weight. Amazing response to some of these meds. Okay, so I'm going to actually stop here. I do have some other slides, but I'm going to stop and take some questions, and I may have to go back to some of the slides that we talked earlier about with regard to the different diets and the fads that are out there.
Okay. Thank you so much, Dr. Ammar, for this
Yeah.
comprehensive talk. Please, our audience, either you raise your hand for a question or you could write your question in the chat box. So I will start with the first question, Dr. Ammar.
Yeah.
I know like exercise are very important for healthy body, etc. However, you touch on exercise maybe not the only answer to lose weight. And I run a lot, long distance, but I don't feel I lose weight. Actually, I read that running, actually, I maybe gain some weight. When you run for a long distance, you may lose glycogen, and after that, you get craving for sugar and carbohydrate. Any solution for this? Like some of us go to the gym and spend like an hour or 2 hours, 3 hours, but after that, you have that craving of carbohydrate. Any solution for that?
So let's start with the craving first, then I'm going to come back to the role of exercise. You're getting craving because you run out of your storage, right? And the body is sensing that, and it's automatically going to ask. So you used up your catecholamine, and now you need to have more sugar. Use up all that sugar. The body's response is going to go through the ghrelin and say, I need to eat. So you're absolutely right, 100%. You're going to actually not only get hunger, but you're going to get specific craving for carbs, particularly as your levels go up. So that is the part that you can minimize. So we advise actually people who are runners is you need to get more protein throughout your run plus the sugar. Don't just do the sugar by itself, because if you're going to do sugar, it's going to increase your insulin. You're going to be hungry again, craving more sugar afterwards. The exercise itself for weight loss, and this is what I said earlier, if you have very effective beta oxidation, your exercise is going to lose weight. However, that's dependent on muscle mass. The amount of calories that we burn when we run is dependent on our beta oxidation. This was very efficient when you were a 20, 25-year-old. At my age, guess what? It doesn't work. I don't burn half the calories that I used to, just not as an efficient system anymore. Sometimes it's partially because testosterone comes down. Sometimes because the body has this ability to accommodate, and particularly for those who are trained. Now, remember what training does. It makes you more efficient in using calories, energy. So I don't need actually 100 calories anymore to run, let's say, for 10 minutes. I could do that in 70 calories. That's part of the adjustment that the muscles make. And that's actually why training is important for those athletes. If you're going to be doing any kind of a professional athlete endeavor where you're going to be expected to train, that is why people train, to become more efficient burning the calories. So you have the two things. One, that you're becoming more efficient just merely because you're training more, and two, because you're not as young as you used to be 10 years ago. This is how this discussion ends up being with the patients. You have to do weight training. What I said about resting expenditure, that is dependent on your muscle mass. You want to bulk up. So if you want to lose weight, and if you want to keep the weight off, you actually want to hit the gym, not running, but hit the weights. You're going to do push-ups and sit-ups, all those things that you actually want to, if you want the weight to stay down.
Okay, thank you. Thank you. Dr. Nizar Daboul, you have a question?
Hello. Yes, I do. Dr. Ammar, excellent job with the presentation. Thank you so much. Couple of questions, actually. The first one, do you have any experience with combining weight loss medications like a GLP with a stimulant like phentermine or not? I know it's not FDA approved for a combination, but do you have any personal experience in your office or your clinic with that?
Yes.
The second question is, you mentioned the pipeline on the last slide with all the medications. There is a new class of weight loss medication, the cannabinoid CB1 receptor antagonist. If you remember, about 10 years ago, there was a trial, a big trial called the Crescendo trial, using a medicine called Ramonabant
Yep,
and
and
that
was
led
killed.
to
That was killed. Yeah.
significant weight loss and got approved under the name Acomplia, but then it got withdrawn from the market because of side effects of depression and suicidal ideation. It seemed like that class is coming back again, and there are another product of the same class called Monlunabant being tested. It passed phase 2, and I think it's going into phase 3 now. And that seems to be another product that's promising in weight loss. This one does not cross the brain barrier, so it's supposed to cause less of the depression and suicidal ideation concern that we're seeing with the Rimonabant. I don't know if you have any more information on that.
So
class
I'll tell
or-
you where I
Yes,
see
go
those
ahead.
going. And this is part of, again, now in phase 3 trials. And the reason it actually was pulled, it wasn't only the suicide, but also psychosis. The FDA appetite for CNS active drugs has been terrible. Ketamine, they want to use actually ketamine. There was a panel not too long ago that sat in front of the FDA for severe depression or ketamine, and they actually declined it. Because it's politically driven, it may or may not be approved. You never know with these drugs. The story behind it is not only about the effectiveness and the safety, but also who's pushing for it. So I don't see it coming back anytime soon with the FDA composition the way it is today. However, things may actually change in the future for the cannabinoid products. Your first part of the question, or your first question, yes, we do use combination, and there's really no reason not to use combinations. Just like you use combinations in diabetes management and hypertension management, these different drugs do different things in the brain, and they belong to different classes. And phentermine is going to work on the neuropeptide wire, like you said, on the right side of the equation, but I could certainly combine to something that's going to work on the left side of the equation as well with the oxygen modulant or with CART. The way that I do it in the office, because it is off-label for sure. Not only is off-label, but when the insurance company sees that you're actually getting phentermine, they're going to stop paying for the other drugs as well. What I usually tell patients, just like what we used to do with hypertension management years ago in diabetes, get drug one first on board, get the maximum effect, not necessarily the maximum dose, but the maximum effect. They're going to plateau, right? So all weight loss is going to eventually plateau at one point in time. And this is what they actually learned, like I said, with all these newer drugs, it's only 20%. It's plateauing at 20%. If you want to push it further, then you'd add another drug from a different class, which what we actually currently do in the office. You lose the first 70 pounds. You still need another 20, 30. You need something to nudge it. Yep, we actually add phentermine sometimes. Sometimes we actually add the Contrape. I try not to add the Qsymia, depending on the individual. But we've used them, and we've used them actually very effectively. And they work. The problem with phentermine, as you know, it's going to be 3 months at a time. In the state of Michigan, they don't tell you how long you need to stop it. In other states, there's a strict 6 months for the year. So you can't use it more than 6 months out of the year, 3 months at a time. So each state has its own regulation regarding these controlled substances. It's Schedule 4. And we know that it's not terribly addictive. By the way, they also had trials before with phentermine 75, not 37.5, which was also felt to be safe as well. So we do use the combination off-label. And I do have patients sign off-label use as well.
Thank you. Dr. Esra?
Assalamu alaikum. I have like 3 questions, please. So the first one regarding the phentermine and the Vyvanse that Dr. Nizar was asking you about. So I know that it accelerates blood pressure and heart rate. So did you see an experience like in office that on your patients, does it really like affect their heart rate and blood pressure dramatically? That's my first question. The second question is
So if you're
regarding.
going to have 3, Israel, then let me take one at a time because I forget.
Okay.
I'm old.
Okay, no
So
problem.
Vyvanse is not indicated for weight loss. It's indicated for binge eating
Binge
disorder.
eating, yeah.
And people have been using it off-label for the same thing. It works on the CART, and the cocaine amphetamine receptor transcript that actually helps with the weight loss as well. In the office, and we've been doing this for literally 20-some years, I'm yet to see really high enough. You get also elevation of blood pressure with Wellbutrin, bupropion. Those drugs are not as strong of a stimulant as when people do their cocaine or they do their Red Bull or when they do, 200 milligrams of caffeine, which they often do. So I haven't seen it in our office clinically significant enough. However, here's my caveat, here's my caution. If somebody's already on blood pressure medicines and they're not taking it, they're not compliant, I would not give it to them. Because even that 2-3 points increase in the blood pressure, if it was on average 2 or 3, that may be actually the one that's going to get them in trouble because they're not taking their regular meds. We have not talked about drug-drug interaction either. Remember, with beta blockers, you have this interaction as well. We didn't talk about glycemia. So topiramate, you can't use it, like I said, in women of childbearing age, but also people who have kidney stones. You can't use it with glaucoma. Neither can you use the Wellbutrin in that regard. So there are some other kind of details that when you go through a specific medicine that you want to use, when you use the combination, we want to make sure that they're actually safe for that use. Second question?
Yeah, so regarding the Zepbound and the Wegovy.
Yeah.
So so of course some patients they reach the plateau, and then some patients when they stop these medications, they start gaining the weight again. So my question is, when patients are like gaining the weight back, is it more gaining it back as fat? Like, did you realize that it's like more as that their weight gain is more like fat? It's kind of like they're losing their muscle more.
So I'll tell you what we know. Step 4 trial was done with semaglutide. They have patients on a steady dose of the Wegovy, and then they stopped for half of the patient. The other half continued with it. Randomly controlled, randomized controlled trial. The patients who stopped the medicine didn't know that they actually stopped it. Gradually over time, the appetite came back. The weight never went back to where it was before. So unlike the ketogenic diets where you lose a lot of muscle, which is really why we were very interested in this molecule, because it makes you lose a whole lot more fat than you lose muscle mass, as opposed to some of the other diets. So yes, the weight did come back. It did not come back more than it was before you started. And it was a gradual increase, as noted by increase in appetite. In the future, and this is what I tell patients, I did not mention this, because patients quite often ask me, well, I can't afford it, et cetera. What's going to happen? I'm like, you know what? If you have somebody with hypothyroidism and you take them off levothyroxine, what happens to their hypothyroidism? It comes back. It's not a surprise, none whatsoever, that when you take these drugs off from their menu, it's their own endogenous, right? So you're replacing a hormone that the body needs. You take that hormone out, the disease is going to come back. Hence, it's a relapsing disease. So we work with them, by the way, on what other method that you could use for long-term use if you need to, or is it affordable, or are there other resources that you can get these medicines somehow? But
Okay.
the weight gain that has been shown in step 4 trial, like I said, it doesn't go back to their baseline. It's still below their baseline where they started off, and it's actually very gradual.
So the weight gain, so you're saying that the weight gain from stopping the keto diet is much more
It's a whole lot more. What we've seen in our office, which has
more
also been
risky.
shown,
Yeah,
well, they gain actually more than they lost.
right.
And the body, again, has not only lost muscle mass now, and it became much more efficient in the use of the energy that's been given to it. Going back to, the exercise that Nidal was talking about. Yeah, the more you exercise, the more you're efficient in using it.
Okay. And then my last question is regarding when patients reach that plateau, when they plateau with the weight. Did you realize, like from your experience, that if the patient, like for example, go off of the Zepbound or the Wegovy for a week or two and then come back on it, do you realize that that might like put them
Sure.
back on the weight decrease?
So I don't know if it
You
really
understand
shot the
my question?
system or just institute. Again, I like to use the hypothyroidism example because it's really very comparable from what we've seen. They come off of it for a month or two, 3 months, right? Ran out of insurance, what have you. They go back on the medicine. It works the same way that it worked before. And unlike what we've seen with the phentermine, where it becomes less effective, my experience has been if they come off of it for a month or 2 or 6 years or whatever, they go back on it, it's as effective as it used to be in the first place.
Okay. Shukran Kathir. Thank you.
And I see Dr. Nizar asked a question about compounded drugs. So I refuse to write for any compounded semaglutide or tirzepatide. And I tell you why I do that. First of all, you know where these drugs come from. They come from China and they come from the Ukraine. Data has been published. This is not me saying it. It has been published. They actually tested the material, the compounded material. And I may offend somebody here who's trying to sell or prescribe the compounding material. So I'm going to be a little bit politically correct. I try to be politically correct. Compounded material have never been tested in human trials for weight loss. That is the reality. 4 states are now suing the compounding company for false claims that it helps lose the weight. It hasn't been tested. We don't know. But when they tested the actual compounded material, they found out actually it has some impurities and some carcinogens. So I tell my patients, I refuse to write for it because 1, it's not indicated. 2, if you come down with pancreatitis because of a medicine I'm prescribing off-label, because it's not indicated for it, you're going to come after me just for you to save $100. So I adamantly, I say, absolutely no. I don't prescribe it, nor do I actually let my patients say, if you're going to do it on their own. We've seen actually 2 of our patients that came in from other practices that have been on compounded material, and both came in with pancreatitis first time. I don't know the prevalence of pancreatitis among compounded material users, but that's how it got to us. So personally, I do not prescribe any compounded semaglutide or tirzepatide. And I've said this before to other folks as well. If it was that easy to compound in a 31 amino acid sequence, we would have compounded insulin a long time ago. It's 80 some, but we could have done it, and we didn't. So now they claim just because, you know, we can get around the rules. I don't subscribe to it. That's all. Now, and that's all I'm going to say about compounding.
Thank you. There is another question, Dr. Ammar.
Yeah.
I have family history of medullary thyroid cancer, thinking to start Wegovy. Do you think I should have thyroid ultrasound before and during, and how
No.
often?
No. So there's absolutely no recommendation to check for pancreatitis beforehand, amylase lipase, or to check for the calcitonin for thyroid cancer. Now remember, thyroid cancer has been associated with these drugs, just to put things in perspective. In humans, we don't have any case yet that ties these actually molecules, the GLP-1 receptor agonist, to thyroid cancer. It's a particular type, that's medullary cell carcinoma. In thyroid cancers, which is very rare to start off with, only 2% are medullary cell carcinoma. They come from a different lineage during embryology. So it's not the same as your papillary and follicular. So 1 is very rare to start off with. 2, there's no recommendation in the insert to actually even check for calcitonin beforehand or during therapy. Now, clearly, if you have a nodule, you want to get it checked out regardless whether you're on a GLP-1 receptor agonist or not. But the link has been actually shown in mice and rats. And we know it's dose-dependent, duration-dependent for the increase of adenoma. That's specifically for the medullary cell. So either personal history or a family history of either medullary cell carcinoma or MEN2 will actually preclude you from having the GLP-1 receptor agonist and DPP-4 inhibitors.
Okay, thank you. One more question.
Yeah.
It's known that 1 gram of fat is 9 calories. When you burn 9,000 calories, do you actually burn 1 kilo of fat, or
No.
it's more complex?
No. So the kilocalorie theory, this is actually the amount of energy that's used to raise the temperature by 1 degree of centigrade in the lab. This is an in vitro testing. So if I want to raise the temperature in the lab by 1 degree, I'm going to burn 1 gram of fat, or I'm sorry, I'm going to need 1 kilocalorie. So I need for that, for each gram of fat gives me 9 kilocalories. And for 1 gram of carbs, it gives me 4 kilocalories. And 1 gram of protein gives me 4 kilocalories. This is in the lab outside the human body. However, I'll tell you what people assume. When we translate this, we say 1 pound per week of weight loss. That's a 3,500 calorie. That's actually only in theory. That is not how the body functions necessarily. So that's derived from that, the 9 kilocalorie per gram of fat.
Okay, thank you. I think we don't have any more question. So if no more question, we'll conclude this webinar. Thank you so much, Dr. Ammar, for this
Absolutely.
outstanding talk Oh, thank you. And also thank you for our audience for joining us tonight. And hopefully we'll see you in 3 weeks on Orlando at SAM Symposium. And to our next webinar, as usual, the fourth Thursday of the month will be February 27 at 8 p.m. Eastern Time. Thank you, everyone, and have a good evening.
Good night.
Good night.